Hello, my name is Toby Capstick. I'm the consultant pharmacist for respiratory medicine at the Leeds Teaching Hospitals NHS Trust. Within this presentation, I'm going to talk about the Community Pharmacy West Yorkshire Respiratory Inhaler Checkup Service. So, what is the challenge? Why are we doing or providing this service? Well, we know that both asthma and COPD has a huge burden of disease in the UK, and particularly across West Yorkshire, we have high numbers of patients on both registers. We know there are a lot of hospital admissions, and many of those, particularly in asthma, are avoidable with better management of patients, including optimizing treatment and optimizing inhaler technique. And we know that in the National Review of Asthma Deaths, we know that nearly half of the people who had died from asthma hadn't had their inhaler technique checked within the prior 12 months. So what's the scale of the problems that we have facing it as healthcare professionals? And we know that in 2010, we had a relatively small number of inhalers available for us to prescribe, but in recent years, there's become more and more inhalers. And it's become really difficult and really confusing for us as healthcare professionals to be able to work out which is the best inhaler for our patients. And because there's so many different inhaler devices, it's become almost impossible for anybody to be an expert in how to use every single inhaler device. And that's why in many areas, the local formularies have rationed down how many inhalers available to prescribe to make it easier for healthcare professionals to know what they're doing and to be able to optimize patients, and so that everybody knows how to use inhaler devices that are used. So these are the inhaler devices available within the UK market, and you can see there's been a wide number of inhalers again launched in the last couple of years, lots of different devices, and we can categorize them broadly into aerosol and dry powder inhalers. On the top row, we see that we have the MDI with spacers that we can use it with. We have the soft mist inhaler, the Respiratory, and we have breath actuated aerosols such as the Autohaler and the Easy Breathe. Within the dry powder inhalers, we have three different categories again. We have a single dose dry powder inhaler, such as Achyhaler and the Ellipta, and these devices, within each device, there is a blister strip that when you prime the device, it either peels the blister or pierces so you can inhale the individual dose. In the middle right, we have the single dose capsule DPIs, where all these inhalers operate fairly similarly in that you put a capsule into an inner chamber, press a button on the side to pierce the capsule, and then you can inhale the powder that's contained within the capsule. And at the bottom row, we have reservoir multi-dose DPIs, and the consistent factor with these is they all have a reservoir of powder, such that when you prime the inhaler, it lowers the dose essentially by a vertical drop. So you need to prime them in the orientation they're shown in these pictures. So how common is poor inhaler technique? And it is surprisingly common. And people sometimes hark back to the good old days when we had just a few inhaler devices that we all knew and loved. And everybody says, well, why don't we stick with those? And the reason for that is we know that many people make errors using these inhaler devices. And in fact, between 1 in 3 and 1 in 10 patients using some of these most commonly used devices make critical, really serious errors that's going to significantly reduce the amount of the drug getting into the lungs. And if we think about our practice and we think 1 in 3 people using an MDI or 1 in 10 using an Achyhaler effectively may as well not be using it, that actually adds up to a lot of our patients. So there's more that we need to do. So we need to teach patients how to use their inhalers correctly. So it's really important that us as healthcare professionals are experts in using these devices. And there was a study several years ago that looking at healthcare professionals, doctors, nurses, pharmacists, and seeing how many of them could use an MDI correctly, and they found only 8% of healthcare professionals can use it correctly. In my experience, that, if anything, is an overestimate. The MDI device is one of the hardest inhaler devices to use, and yet it is widely prescribed. So how does poor inhaler prescribing and inhaler use affect disease control? Now we know in both asthma and COPD, if you have poor inhaler technique, you have worse asthma control, you have more COPD exacerbations. So we'll look at these primary care studies. On the left, we've got an asthma study counting across on the x-axis. You can see the number of errors made using an MDI, and you can see in the shaded bars, the more errors you make, the worse the asthma control is. And then on the right hand side with the COPD study, we see that if you make at least one critical error using an inhaler, you have more exacerbations of COPD than if you have good inhaler technique. The critical study was published 4 years ago now, and this study, one of the analyses it did was looking at what types of inhaler technique errors significantly affected asthma control. And we can see across 3 different inhalers, a turbohaler, an inhaler, and MDI, these are the types of errors, if you made them, you were significantly more likely to have poor asthma control. So if you don't tilt your head slightly upwards when you're using an inhaler, you have worse asthma control. If you don't breathe out, exhale fully before using it, worse asthma control. If you breathe in at the wrong speed, again, worse asthma control, and so on. So these are the sorts of critical errors we want to ensure our patients are avoiding. Another factor that is associated with poor outcomes as well comes down to prescribing of inhalers, and that we often see in our practice people on mixed types of inhaler devices. So particularly they might be on, for example, a dry powder preventer, but they might get a salbutamol MDI as a reliever. So we now have a mixture of dry powder inhalers and aerosol inhalers, and they require 2 different inspiratory maneuvers. You inhale quick and deep with a dry powder inhaler, you breathe in slow and steady with an MDI. And we've seen in 2 different studies now that if you have asthma or COPD, if you have mixed inhaler devices, you have more exacerbations and worse control of your asthma. And this study really highlights that we need to make sure all our patients are prescribed all dry powder inhalers or all aerosol inhalers. Another factor with our prescribing practice that can affect people's asthma control is if you switch and change their inhaler devices, particularly if you don't involve them within the consultation and the decision-making process. And this was a study that looked at two cohorts of asthma patients, one who stayed on their usual inhaler and one who had their inhaler device switched. Often thought to be an easy device, but it didn't involve the patient, and they found that over 2 years, people who had this non-consented switch had worse outcomes. They had worse asthma control and more exacerbations. So it really does show, if we're going to change somebody's inhaler device, we really need to be involving the patient, making sure they can use their inhaler device and that they're happy to change. Another issue comes down to asthma adherence. And if we look at this study from Sami Suisa, published 20 years ago now, and we see that the worse your adherence is, the higher the risk of asthma death. And that we can see for every additional canister of an inhaled corticosteroid, the risk of death was reduced by 20%. And for every additional canister of steroid used during the previous 6 months, the rate of death was reduced by 54%. So it really does show that if you can improve adherence to treatment, either through better education, better inhaler technique, then we will improve outcomes. And the other issue we have to think about with adherence is our patients who are overusing their blue reliever. And if we think about how much SABA, short-acting beta-2 agonist, is enough for somebody with good asthma control, we just have to think that the national guidelines, part of the definition for controlled asthma is using a reliever inhaler no more than twice a week. So a 200 dose inhaler of salbutamol used at 2 puffs twice a week, 4 puffs a week should last 50 weeks. So anybody who's using more inhalers more frequently than this is by definition going to be poorly controlled. And there have been studies that have shown that people who are using a lot of salbutamol have higher risk of exacerbation, hospitalisation and A&E visits. The Sabina study was published last year, which is a UK observational study, and it looked at comparing people who were low users of salbutamol compared to those classed as high users. And in this study, a high user was just using 3 salbutamol inhalers each year. And what they found is at each step of the BTS guideline, people who were high users of salbutamol using 3 canisters a year had more exacerbations, including GP visits, A&E attendances, hospitalizations. So this is other people where maybe the inhaler technique needs to be optimized, maybe their asthma management needs to be optimized. And we do need to remember that when we prescribe inhalers, all our UK guidelines for asthma and COPD, whether it's BTS sign asthma guidelines or the NICE asthma and COPD guidelines, give very similar advice that if we're going to change somebody's inhaler device or prescribe them a new inhaler device, we should teach them how to use it and check they can use that device correctly before we can prescribe it, and then repeat inhaler technique training regularly. And I think we sometimes forget to do that, and it's an area for improvement, and this is one of the reasons why we want to do this inhaler technique service. So if we're going to be providing an inhaler technique service, we need to know a bit of information about how we use inhalers. So when we use an inhaler, there are 3 different ways in which the aerosol can deposit within the airways, and the 3 mechanisms are inertial impaction, sedimentation and diffusion. Now the main way that the drug deposits in the airways is through inertial impaction, so particles with a high inertia, so either a high mass or a high velocity or both, they're going to impact higher up the airways. So you need to have a small enough particle to get down into the distal far airways, or they need to be travelling slow enough to get down there. Big particles travelling very fast are going to deposit in the oropharynx and in the big bifurcations at the upper airways. Another thing that happens is sedimentation. So this is why we advise our patients to hold the breath for 5 to 10 seconds. It just allows time for the particles just to sediment out and deposit on the airways. And the third mechanism, diffusion, only plays a very minor role in terms of aerosol in inhalers. So what this means is if you're using an MDI, which is an aerosol inhaler, when you spray the aerosol, the drug is already propelled out of the MDI at high velocity, sometimes about 35-40 miles an hour. So if a patient breathes in nice and slowly, taking a slow deep breath over 3 to 5 seconds, which is an approximate speed of about 30 litres per minute, we can see from this study that in the yellow bar, 11.2% of the drug deposited in the airways. Now, if they breathe in really fast, taking a quick deep breath, which is what we see a lot of our patients, we see that the drug deposition drops and we lose about almost a third to half of the drug depositing mainly up in the oropharynx, because patients are breathing in too fast and it's got really high inertia and it's now going too fast to get down, make that bend at the back of the throat down into the lungs. And we're seeing the green bar that if you use an MDI with a spacer, you will increase lung deposition considerably, particularly if you're breathing in nice and slow. And we can see that again, the advantage of using a spacer is this is some radio-labelled drug. And what we can see is on the left-hand chart, when a patient uses an MDI by itself, breathing in the medicine, we see that 80% of the drug is deposited right at the top in the oropharynx and is then swallowed into the stomach that you can see below the lungs. And we only see about 11% of the drug deposits in the lungs. Now, when we use a spacer on the right-hand image, we can see that now the oropharyngeal deposition is reduced down to 6%. There's very little in the stomach. There's 21% in the lungs, and there's a lot deposited out in the spacer. So spacers help maximise the amount of the drug that's getting into the lungs, reduces oropharyngeal deposition, so you're going to get less side effects, which particularly for steroids can give you oral candidiasis. And also if you get increased amount of the stomach, you're going to get systemic side effects. So spacers will reduce both of these. And one of the things we should remember is when we're using a spacer is we should spray a single puff into a spacer at a time. In this study, looking at this red zone, the fine particles going to get down into the distal airways that are outlined in red. If you use an MDI directly, the fine particle dose from a salbutamol 100 microgram dose from an MDI is about 46 micrograms. You get larger particles as well, which accounts for that discrepancy. Now, if you use it through a volumatic spacer, using one spray into the spacer, you will increase that fine particle dose. But if you spray 2 puffs at a time, you get a reduction in the fine particle dose from each spray. And if you do 5 sprays at once, spray, you'll actually only get about 20 micrograms per spray. So you're going to reduce the effective dose by more than 50%. So it's really important to do one spray at a time. Now, we can't talk about inhalers these days without considering the environment, because it's one of the NHS commitments is to reduce the carbon impact of inhalers by 50% by 2030. So PCNs are being asked to increase the amount of DPI prescribing and reduce the amount of MDI prescribing. Now, what we see is the reason for this is if you use 2 puffs of an MDI inhaler, it has the same equivalent carbon impact to driving your car about 2.5 miles. So it really is actually quite surprisingly high carbon impact. And we can actually differentiate the different types of inhalers into very high, high and low carbon impact. The very high carbon impact inhalers are those that contain the propellant HFA 227. It's a propellant that causes a carbon impact, and the HFA, the hydrofluoroalkanes, replaced CFCs about 15-20 years ago, which were much higher carbon impact global warming potential. And we can see there's very few MDIs that use this HFA 227. We have Symbicort MDI, we've got Flutiform in the MDI, the K-Haler and the Intal MDI. Now both the Flutiform, K-Haler and the Intal MDI have been discontinued this year, so we're going to see less of those. Another MDI with a very high carbon impact is the Ventolin MDI in comparison to other generic salbutamol inhalers because it's a larger volume canister that has a greater volume of the HFA 134 propellant compared to other inhalers. Other MDIs that have a high carbon impact are pretty much all the other MDI devices that contain the propellant HFA 134. It's got a high carbon impact, but nowhere near as high as the HFA 227. And in the green zone, the low carbon impact inhalers, the dry powder inhalers, and the soft mist respiratory mat inhalers that don't contain propellants. And then for 2025, we're expecting the introduction of low carbon MDIs with a low carbon propellant, which will be similar to EPIs. Now, we need to think about the full environmental cycle of inhalers. In terms of global warming potential, you can see in the red bar, the HFA 227, much higher carbon impact than the blue bar, the HFA 134s. And then you can see that DPIs and the new novel low carbon aerosol, very low carbon impact in comparison. But there are other environmental harms of inhalers, particularly due to the plastic components within the inhalers, and so more so with the dry powder devices, which got a lot more plastic in comparison to MDIs. We can see that the plastics within these inhalers can contribute to environmental damage, particularly through their disposal if they go into landfill, where the plastics can leach out and cause groundwater toxicity. And really the key message from here is that all inhalers do have an environmental impact, and it really is important that we offset this as much as possible by making sure our patients are prescribed an inhaler device that they can actually use and they're happy to use and they do use, because if they're not using inhalers or they can't use it, then you're going to get environmental damage but with no clinical benefit for the patients. And it's also key that we advise our patients to return their used and unwanted inhalers to pharmacies where they can be disposed of safely rather than going into landfill, where plastics will leach out into the ground and propellants from the aerosol canisters can escape into the atmosphere and cause global warming. And when we are thinking about switching patients from using high carbon impact inhalers, we should remember that patients, the most important thing that they want from their inhaler from this study was in the orange blob on the right hand side is the inhaler going to be effective? Is it going to work? Is it going to control their asthma or their COPD? Whilst environmental impact is an important factor, it was secondary to does the inhaler work. So if we're switching people's inhalers just because of the environment, we might upset them if we don't explain that inhalers potentially, if they can use them, are just going to be as effective. And this is why it's really important to involve patients in treatment decisions. And if we are thinking about having an impact on environmental impact of inhalers, we should remember that nearly 70% of inhalers prescribed in England in primary care are MDIs, and the vast majority of the MDIs that are prescribed are SABA inhalers like salbutamol. And there's other NHS BSA data showing that actually 20% of people thought to have a diagnosis of asthma using at least 6 salbutamol inhalers per year. So these are people who are very poorly controlled. They're overusing their salbutamol. So really, if we can actually target people who are poorly controlled using a lot of salbutamol, get them on inhaled devices they can use, optimize their treatment, we will reduce their SABA usage and reduce their MDI usage and carbon footprint. So environmental agenda, really the priority for our patients is to achieve the best control of asthma or their COPD. If you're poorly controlled, they're going to be using more SABA inhalers, have a greater carbon impact. They're going to be attending their GP or going to A&E with exacerbations, which is going to have a carbon impact as well. And overall, remember that the greenest inhaler really is a device that the patient can use and they will use. Again, just to highlight, make sure patients are advised to return their inhalers back to the pharmacy for recycling or incineration in a safe way. And remember, only ever prescribe a new device after inhaler technique has been taught and checked. Low global warming potential inhalers are probably our preference environmentally, but if they can't use the low carbon impact devices, they might need something that's higher carbon impact if that's the best device for them, because that will be the greenest inhaler for those patients. So I'd like to move on now to the inhaler technique service that's being run out of Community Pharmacy West Yorkshire. So I'd like to go through how the inhaler technique service runs. Eligible patients for this service are those people with a diagnosis of asthma or COPD and they're on inhaled therapy. They do need to be registered with a local GP so that you can inform of the outcomes of the service. And patients need to be able to speak and understand English, or you need to be able to communicate in their own language. Patients can have up to 2 consultations, the initial service, and then to reinforce and check their understanding 6 to 8 weeks later if that's appropriate, and they need to be able to attend for both of those consultations. And each patient can have this service once. In terms of the pharmacy requirements, you need to be able to use your consultation room for privacy. It can be provided by either a pharmacist or a pharmacy technician, and you must have completed the CPPE Declaration of Competence for Improving Inhaler Technique to help with a bit of CPD as well. Using placebo inhaler devices is really good, particularly because it's useful for you to demonstrate perfect technique to the patient so they can understand what to do and they can just copy back. That's the best way that people learn how to use inhalers. So have your own placebo inhaler supply. Patients, when you're checking their technique, they can use their own inhalers. An extra dose generally would not be too much of an issue. But if you do want to check with a placebo device, please do. But they are single patient use only, and it is your responsibility to obtain more. And we will get you an initial supply, and you can obtain more through online portals for a small number of devices, or but then contact your local reps for further supplies. So who are the people that we should be prioritising? You can do it for anybody, but I think clinically the people who will benefit the most are those people with poor asthma and COPD control, because it could be that they can't use their inhalers correctly. And if you can improve their inhaler technique, you will improve their disease control. So who are those people who are poorly controlled? Well, they're people who are high users of the SABA, the salbutamol inhalers, and those who exacerbate a lot. So those are people having lots of courses of prednisone, at least 2 courses a year, or they've had a hospital admission. Also think about people who've got poor adherence to their preventer inhalers. It could be that they can't use their inhaler device, maybe they don't like them, so offer that service. Give them some education about how to use an inhaler and why adherence is important. Also target people who are on a mixture of dry powder inhalers and aerosol inhalers. Try and work out which is the best type of device for the patients, and ask their GP to prescribe a consistent device, because that can improve their overall disease control. Also think about people on high carbon inhalers, your Symbicort and Flutiform MDI devices in particular. If they do need MDIs, you might want to consider whether they would be happy to switch to a lower carbon device if they can. But if they're best on a high carbon device, then do keep them on that if it's appropriate. So the consultation format is you can have 2 appointments at baseline and then up to 6 to 8 weeks later. You can book those appointments and obviously take their telephone number or email address to remind them to attend. In terms of the consultation, I will come into a bit more detail, but we're going to be looking at their asthma control, their COPD health status, because then if we do a follow-up consultation, you can actually see the impact on their disease control from the service you've provided. We're doing an inhaler technique assessment in terms of both an inspiratory effort and then teaching and optimizing their inhaler technique. And then other things you might want to do is go through their use of their medicines in terms of adherence, knowing when their medicines are used and what they're for, and then think about the healthy living interventions you might do, like smoking cessation, healthy living. I record the outcome on Pharm Outcomes within 48 hours to get the payment. Any interventions you make, obviously refer to the GP, particularly if you wanted to change the device. Now, in the initial consultation, if the patient's got good disease control or good inhaler technique, you don't need to invite them back for a second consultation. You've already found out that they're doing well. There's no point getting them to come back for a second. It's those people with poor asthma or COPD control, poor inhaler technique, we want them to come back, because then you can see whether the intervention, the service you provided has actually had a good impact. Now, potentially you might be able to carry out an MS in addition to the service if the patient is eligible. There is a consultation form. This is an old version that I've had, but there's an up-to-date form on the on Pharm Outcomes and the Community Pharmacy West Yorkshire web page. So consultation again, we've gone through in terms of assessing asthma or COPD control. How do we do that? Well, we use the asthma control test. You can find a version of this online as well if you haven't got the paper forms. It's a 5-question questionnaire. Each question scores from 1 to 5. You can get a total score of up to 25. We can see the questions are over the past 4 weeks. How often did the asthma prevent you from getting as much done at work, school or home, so affecting your daily activities? Question 2 is, how often are you short of breath? Question 3, how often are you getting nighttime symptoms? Question 4, how much are you using your blue reliever inhaler? And question 5, like patients, how do they rate their overall asthma control? And you're going to score that being anywhere from 20 and above is good. Asthma control, we're happy with that. Anything less than 20 is poor asthma control. And see if there's anything we could do to help optimize that through improving inhaler technique. This is a COPD assessment test. You can download this off the internet. 8 questions here, looking at cough, sputum production, chest tightness, exercise tolerance, limitation of activities, confidence living in the home, sleep and energy levels. And we can see that you can get a total score from 0 to 40. Anything less than 10 is low impact of health on your health from your COPD symptoms. Anything above 10 is worsening impact on health status. And if you repeat this 6 to 8 weeks time, a change in score of at least 2 units is clinically meaningful. In this part of the presentation, I'd like to talk about the evidence base that guides us to understand what the best way to check and optimize people's inhaler technique is. And we have this interesting study from Ayman Bashetti and colleagues, and what they wanted to do is understand how we could teach people how to use their inhalers correctly. So they had a cohort of patients and they assessed their inhaler technique with a turbohaler as being either optimal, being perfect, satisfactory, some minor errors but no critical errors, or unsatisfactory. And they said, show me how to use the turbohaler. And then we see on the far left that 60% of people had unsatisfactory technique and nobody was perfect. So what they did is gave them verbal advice on how to use a turbohaler device. They read out the patient information leaflet, and we see now only 40% have got unsatisfactory technique, but nobody's perfect. So obviously just reading your patient information leaflet isn't the answer. So then repeated a second cohort of patients, and this time they gave augmented verbal advice, where they read out the patient information leaflet, but they emphasised the critical steps. So for example, to use a turbohaler, first thing you do is you remove the cap, you twist the cap off. Now remember, take the cap off, otherwise you're not going to be able to inhale any of the dose. And by emphasising these critical steps, we see that a quarter of the patients have now got perfect technique, but there's still about 40% who still have got unsatisfactory technique and haven't got the full message. So a third group, they did exactly the same again, but they actually demonstrated how to use the turbohaler correctly, and we now see that 80% has got perfect inhaler technique and the rest are satisfactory. So really, this highlights that if we're going to teach somebody how to use an inhaler correctly, the best way to do that is for us as healthcare professionals, as pharmacists, to demonstrate the correct inhaler technique. They then took this study into a practical aspect in a community pharmacy study, and they had cohorts of patients who were newly prescribed a Seretide Accuhaler or a Symbicort Turbohaler, and they used placebos and they demonstrated perfect technique, got patients to demonstrate the technique back to them. If they were perfect, great. If they weren't, they then demonstrated technique again and repeated that 2 or 3 times to get people perfect. They also completed inhaler technique labels, and they highlighted the steps that patients kept forgetting to do correctly. So you see for the turbohaler there, this patient forgot to keep the inhaler upright when they're priming the inhaler. So they highlight that step, helps the patient remember when they're using their inhaler, they see that, and it hopefully highlights to them to make sure they do the inhaler technique correctly. They then looked at inhaler technique maintenance over a 6-month period. And what we see is in the dark line, people with intensive inhaler technique training using the Symbicort Turbohaler or the Seretide Discus, it's an alternative name for an Accuhaler. We see in the dark line they've got much better inhaler technique scores compared to standard care patients, where the standard of care is often probably, here's your inhaler, we'll see you next time. They also looked at asthma control with the asthma severity, and they see in the intensive inhaler technique training on the left hand bar graph, we see significantly fewer people with severe asthma symptoms compared to the control arm in the right hand bar graph, and significantly more with only mild symptoms. And this study really goes to show that if the only intervention you make for your patients is you teach them how to use an inhaler correctly, you will significantly improve their asthma control. So how are we going to go through the inhaler technique assessment? And this is the main part of the service. It's important we do this right. So first thing we want to do is check people's inspiratory effort. We want to know that people are physically able to inhale through their inhaler devices. Now, in previous iterations of this service, we've used the in-check dial G16 inspiratory flow meter. Now, at the moment, we'd like not to use that, and that's partly because of the infection control reasons, and even the one-way mouthpieces might not be adequately antiviral. So really what we need to do is just ask the patients and observe them breathing in through different maneuvers. So literally all you do is just ask the patient to just breathe out comfortably as far as they can, lift their chin slightly up, and that just narrows the angle that the aerosol will go down to get down into the lungs. So breathe out comfortably, lift the chin slightly, and then ask them to breathe in slow and steadily. Can the patient take a slow, steady breath in over 3 to 5 seconds? So a bit like this. And if they can take a slow, steady breath, that's the speed you need to be breathing in to use an aerosol device like an MDI, a Respiratory or breath-actuated MDI like an Easy Breather or an autohaler. If you breathe in too fast with an aerosol, because the aerosol is actually traveling about 35, 40 miles an hour, if you breathe in fast, all you're going to do is accelerate that aerosol, and it's actually going to go too fast to get round the corner at the back of the throat, and most of the drug will impact at the back of the throat. It's not going to get into the lungs. Then, secondly, ask our patients to breathe in quick and deep. Can the patient take a quick, deep breath in within 2 to 3 seconds? A bit like this. And if they can do it quick and deep, they can use a dry powder inhaler device. And we should give those for patients who can inhale quickly and deeply. And that's because when you're using a dry powder inhaler device, you're sucking up a powder. And if you breathe in slowly, all you'll do is suck in that powder as one big clump. It'll hit the back of the throat. It won't get into the lungs. By breathing quickly and deeply straight from the initial inspiration right at the start, you create a lot of turbulent energy which breaks up that clump of powder, deaggregates it to fine particles that are going to get down into the lungs. So once we've done that, as we decide which is best, a dry powder or an aerosol, go with what is the most natural maneuver for those patients. So moving on to step 2, check their inhaler technique. Ask the patients to use their own inhaler and then use the inhaler device guide that's supplied as part of this service, and you can use that as a checklist to determine whether people's inhaler technique is optimal, satisfactory or unsatisfactory. Optimal being perfect, they've ticked all the steps, done correctly. Satisfactory is they're actually really good. They might have made some fairly minor errors, but they've done all those critical steps correctly. And unsatisfactory is where they make at least one critical error that's going to significantly reduce the amount of drug that gets into the lungs. And then moving on to step 3, if patients don't have an optimal inhaler technique, then the pharmacist or the pharmacy technician should demonstrate correct inhaler technique to the patient. Then once you've done that, they can then copy it back and hopefully you take that learning and improve their inhaler technique. If they're using an MDI, do issue patients with the Aero Chamber FlowView Plus where it's appropriate. And that would be appropriate for most people who are using particularly higher doses of steroids or even any dose of steroid. Particularly useful as well for people who are using the salbutamol during exacerbations. And the other really important thing is we should be trying to ensure that patients are prescribed consistent inhaler devices. And what I mean by that is that patients have all DPIs, all dry powder inhalers, or they have all aerosol devices. So really, we should be giving patients all inhalers where they have to breathe in quick and deep with all their inhalers, or they have to breathe in slow and steady with all their inhalers. We know that if we mix dry powder inhalers with aerosols, you've got different inspiratory manoeuvres for different inhalers. It confuses the inhaler technique message, and people actually do have worse outcomes from the asthma and COPD, worse control and more exacerbations. So if you've got somebody who is on a, let's say, a dry powder preventer, make sure they are given a dry powder reliever for managing their day-to-day symptoms. They might need a salbutamol MDI for severe exacerbation, but that's just for managing exacerbations. Symptoms would just be with a dry powder inhaler. Step 4, it really is, again, it's just rechecking inhaler technique. Once you've taught them how to use inhalers correctly, get them to demonstrate it back, ensure they've taken on that learning, and it helps you as a pharmacist and a pharmacy technician to check the patient's understanding and to reinforce any difficulties, any steps that the patient's just struggling with, you can reinforce that. So really, I just put this in as a useful guide for helping you decide what type of inhaler device to use. And it's an inhaler choice algorithm that I helped develop with colleagues across the country. The link is at the bottom of the slide. And we want people to act on inhalers. As I said, assess their inspiratory manoeuvre. As I was saying before, can they breathe in slow and steady? Can they breathe in quick and deep? And that guides the decision. You choose then either an aerosol device or a dry powder inhaler. And I bring this in at this point because actually we need to be thinking about the environmental impact of inhalers. And the NHS wants us to consider prescribing low carbon footprint devices, which are dry powder inhalers and Respimats, which don't contain aerosols. Or don't contain the aerosol propellants. And it's the propellants that are in the MDIs that are greenhouse gases. They're not as bad as the CFCs that used to be in there, but they do have a significant global warming potential. So if people can breathe in quick and deep, that's a natural manoeuvre. Use a dry powder inhaler. If they can only breathe in slow and steady, and that's a natural inspiratory manoeuvre, give them an aerosol inhaler. That will be the greenest inhaler device for those patients. And then train your patients on how to use your inhaler techniques. So we do have a range of different inhaler devices as we've seen before. So obviously with the aerosol inhalers, the important message is inhale slowly and steadily. If you breathe in too fast, you'll just accelerate that aerosol. It'll all hit the back of the throat and it won't get into the lungs. You'll lose up to half the dose and it will affect their asthma and COPD control. If you're using a dry powder inhaler device, inhale quickly and deeply. You need to breathe in quickly, deeply and forcefully to break up that clump of powder, deaggregate it into fine particles and then get down into the lungs. So what are the 7 steps to inhaler technique? And again, the inhaler technique guide that's on which is within your packages, they will go through these 7 steps within each inhaler monograph. So each inhaler, we need to prepare the device. So check the dose counter, make sure it's not empty. Many inhalers need to be shaken before use, particularly a lot of the aerosol devices and some of the reservoir devices. If in doubt, shake the inhaler. You're not going to cause any major problems by shaking an inhaler that you don't need to shake. Step 2, priming. So often this is a case of you might need to prime an inhaler before using, such as the MDI. Sometimes you'll have to spray a couple of doses before it's used. The first time you use it at least. Some of them you need to open the inhaler, click a lever, remove the cap. Step 3, exhale. Get the patient to breathe out completely and away from the mouthpiece. If you're using a dry powder inhaler and you exhale into the inhaler, you will blow the powder away and you'll lose the dose before you get a chance to inhale it. So that's quite a critical error. Step 4, in the mouth, put an inhaler into the mouthpiece with a nice tight seal around the mouthpiece with your lips and tilt the head slightly upwards, and that just narrows the angle at the back of the throat. Step 5, inhalation. So if it's a dry powder inhaler, you inhale quickly and deeply. If it's an aerosol inhaler, inhale slowly and steadily. Step 6, breathe the breath holding maneuver. Hold the breath 5-10 seconds or as long as it's comfortable, and that just lets the medicine settle down in the airways. And step 7 is closing the inhaler again, replacing the cap, or if needs be, having that second dose. And I just want to share some initial data from the first inhaler technique service that ran prior to the COVID pandemic. And we presented this data at the British Thoracic Society Winter Conference in December 2019. And we had data for the first 14 months for 380 patients. And what we can see from the table, that top line, we can see that 28% of patients had not had any training on how to use their inhaler device prior to receiving this inhaler technique service, which is an incredible statistic. We see that half of the patients are prescribed at least 2 inhalers and 4% have 3 inhalers. And then we can also see that more than half of the patients in that bottom row are prescribed different types of inhalers, a mixture of dry powder inhalers and aerosol. Looking at the graph, we can see that the initial assessment showed that more patients could use a dry powder inhaler than using an aerosol, and that was statistically significant. But whether patients were using an aerosol or a DPI, the vast majority would manage to improve their inhaler technique to achieve good inhaler technique. So that's optimal or satisfactory. There are a number of resources available to you and your pharmacy staff to help improve your inhaler technique. I would really recommend looking through the Asthma UK inhaler technique videos. They're about 3 minutes each. Very short video effect of all the most commonly used inhalers in the UK. And you can use those for yourselves, but also you can signpost your patients to these videos to support them and refresh their memory after your consultations. We also have on the right hand side the Leeds inhaler device guide, which is available for you, and you can see for example at that bottom right image you can see the 7 steps checklist that you can use to guide your consultation. Right Breathe is also another fantastic resource which is available as a web page and also as an app. It does have another series of inhaler technique videos as well, but one of the other things that's really good is you can set this up as a patient, and you can use it to search for different inhalers using the search function. And then when you click on an inhaler, such as here we've got the Foster inhaler, you can actually click on the blue button there just below the Foster inhaler image, and then you can use that to set reminders, and it will you can set the time to say I'm taking it 8 o'clock in the morning and 8 o'clock in the evening, and then you'll get an alert on your phone to remind you to use your inhalers. And that's quite a good little resource to help improve patients' adherence to their regular treatment. Now, further support for your patients, you could signpost people to the British Lung Foundation has a lot of really useful information for people with lung disease, particularly COPD, a whole host of different patient resources. Asthma UK is another very helpful website for people with asthma. And then you've got the inhaler technique videos that we've gone through. And then one thing that's really good as well is for that peer support for patients is the British Lung Foundation have Breathe Easy support groups, which you can signpost patients to, and they can just get in touch with their local support groups, and they have singing classes to help give that peer support, bit of education and bit of exercise classes as well. And finally, to end the consultation, it really is good to round off the consultation by summarising the key points that you've covered. In particular, the inhaler technique, and maintaining good adherence to treatment. Any features you can do that helps a patient with that. Some of that will be education about the different medicines, the roles of preventers versus relievers, but also think about the other aspects in terms of their lung disease. So in current smokers, very brief advice to highlight the benefits of stopping smoking. Do think about the vaccination status and think about whether they're eligible for flu vaccine each year, the pneumonia vaccine once as an adult for COPD patients, and also make sure they're up to date with their COVID vaccinations as well. And also think about healthy living tips as well. A good balanced diet, drinking plenty of fluids, particularly for COPD patients to help with sputum production, and make sure that people are getting plenty of exercise as well. Obviously, confirm any issues that you're going to refer back to the GP. So that might be a change of inhaler device. And if you are recommending a change of inhaler device, do make sure you've got the patient's consent and they're happy with that. And don't forget to send it to the GP as well. Finally, ask them if they've got any questions, anything they're unsure of. And for the people who've got poor asthma or COPD control at baseline or poor inhaler technique, do try and arrange that follow-up appointment in 6 to 8 weeks, because then you can see whether they've maintained that improvement in inhaler technique to demonstrate that the education you provided has really cemented into their daily use of inhalers, and see whether that's had an impact on their asthma or COPD control. And then do record the consultation on pharm outcomes within 48 hours to get payment. So that is a brief summary of the inhaler technique service. I really do hope this has been helpful. I really do think it is invaluable for our patients, and we know that if you can improve inhaler technique for your patients, you will be doing them a great service, because it will improve their asthma control, improve their COPD control. And we know that a lot of patients have never been shown how to use their inhalers, so you're actually going to make a really positive contribution. Thank you very much for listening.